about polysubstance use and the use of mHealth to understand, to try and get at polysubstance use from the perspective of drug users, but just for a little bit of background and context, like, I became interested in this kind of stuff while doing a cell phone based daily diary study of women who were engaging in street level sex work in Indianapolis. We were using these cell phone diaries to assess the context of HIV risk twice a day, really trying to use both quantitative and qualitative methods to explore the deep context of sexual events to try and understand HIV risk from the women's perspectives. And what we heard from women was that being involved in this study posed a lot of benefits. And so we did a quantitative analysis looking at mental health measures pre and post, and we saw that self-esteem went up, depression went down, anxiety went down, and then there were some other measures of social support and things like that that didn't move. But when we looked at trends in secondary analysis, we saw that it was really the women who were the most vulnerable who experienced the greatest amount of benefits. So women who were using more drugs, women who started with lower rates of mental health to begin with, et cetera. And so recognizing that, and also then sort of hearing through the qualitative interviews that the cell phone diaries and also these weekly meetings that people were doing with us had intervention effects, even though the study wasn't designed to have those effects, is what prompted me to want to look at the ethics of these issues, especially in the context of polysubstance use, which frankly we don't know a ton about. We just say that people are polysubstance users and like who's not. Right, like who doesn't take it, who had never ever, taken some kind of like antidepressant, for example, and had a cocktail. I mean, just what I mean. I think that we forget that like this is a very normal part of life, and also that these tools are used a lot to understand these illegal and highly stigmatized populations. So that's how I came to this. As an aside, I have an R21 looking at PrEP with women who inject drugs, so I already want to talk to you about some of your work. But that's just also the context in which I work. I do a lot of community engaged stuff with vulnerable populations, and that just I think reflects the fact that I came to academia sort of non-traditionally. Like I worked as an HIV case manager, and then I was like, okay, now I want to go work in prevention, and so I got a master's degree, and then I worked for a while after that. And then I was like, okay, well, I'm not going to mess this up more than anybody else, so I want a seat at the table, and then I got a PhD. So I think that the idea of doing community-engaged work matters a lot to me, and so I try and think about that in the context of all of that, of this work. And so I'm going to talk, I'll move my slides. I'm going to talk about two studies. I'll go through the RETI fellowship study pretty quickly because you guys read the paper. And also you have Erin's paper, and I think the reason that I was interested in you guys taking a look at these two different studies was more about the approach, right? Like Erin and I were both thinking about how do we use mHealth methods, cell phone based mHealth methods in particular, to think about risks and benefits, but I was doing things like a priori, like, what are your anticipated risks and benefits, whereas Erin was able to think about now that you've gone through this study, what did you experience? And I think that that's an important distinction because we know that perceived risks are often very different than what people actually experience. And so in a few minutes when you guys get to talk, it would be great to hear more about, I read your MRPs, and so I know some of you are thinking about anticipated risks and some of you were talking about actual risks, and many of you were working in really interesting, highly stigmatized populations who are engaging potentially in illegal behavior, and so I think those things are really salient. And then if there's time, I'd love to use a study that we're getting ready to launch as a basis of the conversation to teeing up, like, how do you think about anticipated risks? So I'll talk about the use of biosensors to characterize the physiological context of opioid use and outcomes quickly, and then we'll try and use that as a launching place. Okay, so mHealth leverages the capabilities of mobile devices to monitor behavior and deliver health care. However, the harms and benefits of using these approaches have yet to really be systematically assessed. There's a bunch of studies, most of which have been done by Celia's fellows and others who are working in this area, but it's sort of like a discussion point, right? Like empirical ethics around health research is really still an understudied area. And to this day, none of us have gotten around to writing these like best practice guidelines. And this is really important because IRBs often don't know how to handle these kinds of projects. They may kick things up to full IRB review when they don't need to be there. They may push back on the way that participants are getting paid. There's a whole lot of stuff that goes into assessing the risks and benefits of these kinds of studies. So these best practice guidelines are really important. So hopefully, like, we can get all of the fellows in a room someday to write them. But so some of the potential risks in health research is that, you know, people can be put in danger of physical violence if somebody wants to steal their device, or if someone just borrows it and they're trying to get it back. We're asking them about illegal behavior that's highly stigmatized, and that can be, those questions could be seen, or someone could find out, hey, all of a sudden you're carrying this new cell phone. Where did you get that? How did you get that? And in the case of the women in Indianapolis, like, they were very willing to talk about their HIV specific risks, but they weren't willing to talk about their drug related risks. We had proposed to use GPS tracking to understand the context of their daily lives, and they pushed back and they said no, right? Like, I'll tell you the intersection where I had sex because that's relevant to your study, that's what I signed up for, but I'm unwilling to allow you to track me because I'm worried about, you know, the police having access to my data. Okay, well, we have a certificate of confidentiality. Okay, well, I'm worried about the perception that the police could have access to my data. So all of these things are really important. In addition, there's high level of participant burdens. You know, often in health studies, you're seeing behavioral assessments of 2 to 5 times a day. Those can either be at pre-specified or random times. Either way, that might not be congruent with your particular lifestyle. And then there's these fairly generous compensation structures. And so thinking about, you know, do people really, can they really say no if they don't want to participate for whatever reason? And so there's lots of potential risks in health research. And then there's also these benefits. And these have been documented in both diary and interview studies. So, and, you know, we've seen increased self-awareness, empowerment, and ability to manage emotional reactions. It can have some effects on cognitive processes, which then might help participants to think about the predictors and consequences and correlates of their behavior, in which they then begin to self-regulate in some way or another. So these studies have the potential to really serve as interventions even when they're not intended to. So the goal of my MRP study was to explore participant perspectives on the potential risks and benefits associated with participation in this hypothetical health study of polydrug use. And just as a blanket statement, like, I don't love hypothetical studies. I don't love, like, in health behavior, we often study intention, like the theory of reason action specifically focuses on intention. You know, like, I think in a real, like, understanding what happens in people's behavior in the real world is, like, so much more useful and provides so much more meaning. But in this particular circumstance, we wanted to do this pilot work as part of planning for a larger study that, you know, like a K or something like that, which didn't end up happening. But, you know, hypothetical nonetheless. So participants were recruited. They were recruited in 2 different cities. There were 20 or so participants from San Diego, where I was doing my postdoc, and then another 20 or so participants who were recruited from Prudential Point in Philadelphia, which is the largest syringe exchange in the Mid-Atlantic. And they were told that they were going to be helping us design a longitudinal study of polydrug use. And I knew that I wanted participant perspectives because of what had happened in Indianapolis, where I had proposed to GPS track people, for example, and they said no. So I knew that, like, people had strong opinions about the way these kinds of data would be collected. So a priori, I wanted to try and get at those. We wanted them to think about both simultaneous polydrug use, so think about, like, speedball injecting heroin and cocaine at the same time, and sequential polydrug use. So I had a shot, I took a bong load, I did whatever, right? So people, yeah. And then the reason is because polydrug use is associated with negative health outcomes, including overdose in particular, right? The triad, the sort of negative holy trinity for drug overdose is alcohol, opioids and benzodiazepines, and so I was really interested in trying to think about that. In the literature, we basically see people lumped as polydrug users or not polydrug users. That's not a great distinction for all of the different ways that people choose to use their drugs. So people were at least 18 years of age. They reported injecting illicit drugs within the last month, and they reported at least weekly polydrug use. 38 participants. The mean age was 45 years. Most were male, most were white, and most reported being homeless. The San Diego sample is reflective of the larger RO1 from which I recruited, and the Philadelphia sample is reflective of the clientele of the syringe exchange from which I recruited. And so to get at trying to get people to think about risks and benefits, what we did was have them come in and do the hypothetical simulations of the cell phone diary a couple of times. So they were handed a phone, they were trained on how to use the device, and then they went through the diaries, which they were quantitative. They had branch logic, so depending on what people said, they got a series of questions. If they said no to everything, they were diverted to a second set of questions about sort of innocuous daily activities, just to try and keep the length of time of participation, whether you reported a lot of drug use or no drug use at all, about the same, so that there's no disincentive for accurate reporting. And then people were interviewed about their experiences. So things like, how do you think completing diaries might impact your life? Can you think of any bad things that could happen as a result of answering the question over time? Could you imagine any circumstance in which someone seeing you answer these questions on the phone might be good or bad? Can you tell me a little bit about what that is? And then we did a qualitative content analysis of the interview text to look at ethical themes. And so what we found was that all participants reported potential indirect benefits associated with participation. Many of them felt that these repeated behavioral assessments would be a positive influence by encouraging reflection and increasing their self-awareness about their drug use. In particular, people really like the idea of having their expertise in their drug use being called upon instead of being stigmatized, and this idea that they could be helping other people that they deemed as vulnerable. And then the use of the phone was a benefit alone, just having a phone to be able to talk to friends and family or apply for a job, but also the payment for participation were economic benefits. And so as it relates to this idea of reflexivity, people said things like, it would make me reflect on my day-to-day activities, making it more clear as you're answering the questions where you should be putting in an effort to make a change. It's like putting a mirror up in front of you. And anybody who's ever done like a diet app is very, can think about how that would be salient to their own life, right? This idea of being recognized as an expert. So if you take heed of what I talk about, I feel like, all right, I did something. I'll feel good about myself. It makes me want to do other things to make me feel good about myself. So this idea that like, A, you'll learn, and then B, I get to feel good because I'm teaching you about something. And then maybe I'll do these other good things. If what we're doing is going to stop someone from getting on or help someone getting off heroin, let's do it. I wouldn't wish this on anyone. So people are really interested in helping in their communities. And then on the flip side, when they talked about their potential risks of participation, these were much lower in relevance compared to the benefits. People listed and were much more excited to talk about the benefits of being involved compared to the risks, but they did acknowledge that physical risks could arise from carrying a cell phone. That behavioral or psychological risks could stem from these repeated disclosures of mood, and especially negative mood, or behavior that they felt embarrassed about. That legal risks that might arise if law enforcement obtained any information at all about the participants, and then informational risk rose from this unintentional disclosure of drug use or other stigmatized information more broadly. And so, about the risks, the physical risks, people said, it's hard to keep stuff of value when you're using drugs, you know what I mean? Some people have it harder than me. When you're living with vandals, you don't have no security. I know people that wouldn't sell their stuff and they get their stuff stolen just because they nod out. Once I fell asleep and when I woke up, I didn't have my money, I didn't have this, I didn't have that. And so, you know, that's really important when you're designing cell phone-based studies. Like the one we're doing right now, people have to have a phone to participate. That's a barrier to participation that I think really poses some important justice questions. Whereas with the cell phone study in Indianapolis, I provided cell phones to everybody, which is also might pose some justice questions with relation to like the fact that people are getting this thing that they highly, highly value, right? So this is a complicated issue on either way you play it. With regards to psychological risk, they said if a participant is constantly reminded that they're in the bottom of the barrel and feeling depressed, constantly having to go over how they feel could make them more anxious and want to commit suicide or overdose. That's really important, and it plays into the kind of work that you need to do up front when you're talking about informed consent, and also thinking about the kinds of technology-based alerts that you might want to receive as a researcher as you're doing these kinds of studies. So with the cell phone study in Indianapolis, for example, if a woman reported that she had been raped, which there was many reports of sexual assault, none of which were actual sexual assaults. They were data entry error, which brings up a whole set of validity questions. But when they reported rape, we had an RA follow up with them within 24 hours of receiving that. They also got a flag that sent them to the local crisis center and a center for hope. And I think that these kinds of things, like if you were assessing mental health daily, for example, and if you got really horrible, high rates of depression and anxiety every day for a couple of days, that might be something that you as a researcher might have some sort of ethical sense that you might want to follow up with people about that. And to that end, the person said, here, they gave us advice. They said, listen, tell people, you're going to have to constantly monitor your mood. I want you to be aware that during the course of what's going on in your life, if something bad was to occur, that it would make you in a bad mood or irritated, that you need to be aware that you'll be constantly reminded of it. So he's telling us the study's annoying, right? Basically. But he's also giving us, this is the point, right? People can give you really good advice about the kinds of protections that you need to be putting in place for themselves or their peers, right? And that's exactly what he did. I don't know that I would have said, hey, we're going to constantly remind you of all of this bad stuff, as opposed to we're just going to be asking you about your life. And if you're reporting bad stuff every day, it's a different way of looking at the same sort of actions. And so just, in conclusion, engagement in these health studies might confer important benefits. Risks were described as unlikely. However, it remains important for researchers to implement reasonable safeguards. And as health becomes more widely used, it will be important to conduct research on harms and benefits. Actual harms and benefits could be different than those reported here. Again, we were just asking the people to think about what would happen if they did these diaries a couple of times a day. And we asked them to do that conjecture after only doing the diary 2 times, right? So very different. Do you guys have any questions or anything about this study?
You might want to just go to the other one, because once we start with questions, it'll go until 11:15. So
okay.
10:45 whenever we're supposed to stop.
So I'll tell you a little bit. So this one I think is even more fun. In this study, we're going to be asking people about the actual harms and benefits of doing this health project. But for now, as we are pilot testing and we're writing our informed consent, we're asking people to think about these same sorts of things that we did in my RETI study. But now we're talking about something that's even less known. People, cell phones, people get. Daily text messages, people get. Diaries, maybe they have to extrapolate a little bit, but these are wearable biosensors. And if you've never worn a Fitbit, then, and a lot of folks haven't, then how do you even conceptualize that? And in particular, thinking about using these biosensors to contextualize opioid use in the context of a fentanyl saturated opioid market in Philadelphia, working with like people who are saying I'm injecting at least 3 times a day. So these are very high intensity drug users, and they're being recruited from this naloxone intervention, which is basically like Uber for overdose. So I'll set these up. So let's see. So the Uber for Overdose study is a large parent RO1. It's called Unity Philly. And the idea is that we can activate groups of lay first responders to increase or decrease the time in which people receive intervention when they need it. And the study is being conducted in the Kensington neighborhood of Philadelphia, which has been in the news a lot. It is the likely site of the first overdose prevention site in Philadelphia, potentially in the U.S., if we can get our lawsuit to be dropped, the federal lawsuit to be dropped, we'll see. And there were 1,207 opioid overdoses, 84% of which were fentanyl related in 2017. 20% of those happened in the Kensington neighborhood. That is more than double than the next highest neighborhood, which is the neighborhood that's adjacent, and then like way more than anywhere else in the city. I've never seen an open air drug market quite like the one in Kensington. You can't walk down the street and not see folks who are in a heavy nod, publicly using their syringes everywhere. And people are just like sub. So it's like you've never, it's a crazy spot. It's also remarkable and amazing and a really resilient community. But that's the context in which we're working. So the first aim was to identify the barriers and facilitators and acceptance of the smartphone app. And now we're in this pilot testing phase. So the goal was to recruit sort of 55 community members, folks who may not be heavy drug users, and then 55 folks who are more heavy drug users, to just see what happens when people are given this like Uber for Overdose app. And the way that it works, I think that there are pictures, are essentially like you open the app, you press this button, this Unity Philly thing comes up, it shows you like this is McPherson Square, which is like a public park with a library. And you know, it shows you like where the person is. There's like push to talk so you can communicate with one another. Okay. So that's this larger parent study, which we could think about all of the many health ethical issues associated with that. From this study, we're recruiting 20 people, 16 people, who will participate in a biosensor study. So the biosensor study is called SENSED. And essentially the thought is that we have these great biosensors. Truth be told, I'm not sure that they're that great for this purpose. Most of the biosensors that have been used to monitor respiratory rate, which is like the hallmark of opioid overdose, people eventually, like their breathing just slows down so much that they die. Most of the sensors are for sleep apnea, and so they're for people who are like horizontal, and then there's these sensors that monitor how much their chest is increasing or decreasing. We're trying to use sensors that measure like blood oxygen saturation as a proxy for respiratory rate, and then we just found another one that actually does have respiratory rate, but they're not that great. But the idea would be that if we can figure out if these devices can work for these purposes, that then we could retool them for intervention, right? Like it could be the case if something picks up some sort of risky predictive pattern of slow drug use, like, you know, slowed breathing plus no movement, we might assume that they're in a heavy nod. And if that were to go on for too long, we might think, okay, slowing down, even more slowing down and breathing, that's probably an opioid overdose. So we could program the device to like buzz and ring to see if it could stimulate the person into moving. Once they're moving, they're breathing, great, done. If not, it could sound an alarm to alert bystanders. So think about something as loud as potentially like a fire alarm that would draw people in, and then people would be right there. And then lastly, it could be used to pair with something like the Unity Philly app, where it could automatically call for lay first responders and or EMS. We know that wearable biosensors have been used to improve outcomes for a whole host of chronic conditions, but they've yet to be applied to opioid overdose. So these are the two devices that we're thinking about. The oxytone is a sleep apnea device, a COPD device that's wrist worn. It gives you SpO2, it gives you pulse, it gives you activity, skin temp, and then the Spire Health Tag actually gives you respiratory rate plus all of those other things. The Spire Health Tag, this is bulky and has to sit like perfectly on your wrist or it doesn't work. And then the Spire Health Tag, for guys, it can just go in your pants, and for women, they suggest that you put it in your bra strap. And you can see, I wish I would have brought them, but this guy is like flat, it's lightweight. You can really forget that it's there. And they'll give you enough Spires per person that like a person could put them in their like 8 sets of underwear and they can go through the wash, and they have 8 months of battery, whereas this guy is not quite as good. But so the goal for AIM-1 is to demonstrate the feasibility of using these wearable biosensors to capture incidence and physiological responses to opioid use. So my friend Ben, who's a doctor, and I have been thinking about what are all of the different ways that we can characterize the incidence and physiological responses to opioid, cocaine, and polydrug use, right? So just even, we don't know a ton about like near misses, and we have a hard time distinguishing between a really good high, a good nod, and something that might be considered potentially risky, and then how that then translates into an actual overdose event. So we don't know that. We don't have a great way to know how the body physically responds when somebody like administers like a stimulant like cocaine or methamphetamine with heroin. And so that's our first goal, is just to see like, can we pull down these data from the Spire and do these quantifications. The second goal, which I think is even more fun, is to show people who use drugs these different graphs about their bodily functions, and to look at like potential anomalies, and to try and use that to walk back with them to understand these drug use events, right? So you would start with something like, let's talk about yesterday. Where did you go when you left here? Try and do some sort of timeline follow back over the preceding 24 hours, elicit the number of drug use events, and then we're going to use these surveys to try and capture like where people were when they used, how much drug they used, and if they think they did too much, too little, or whatever. Using these biosense data is a way to get that conversation going. So like a talking device. And people will get paid $20 a day for these 60-minute interviews, and then $30 for returning their device. And then the third aim is to try and talk to people about what it was like to have these data collected over the course of the preceding 5 days, with the plan being to use like the updated common rule and the guidelines for mHealth to try and inform some more guidelines for mHealth, and in particular biosensors. And so since it's 10:17 and surprisingly I'm on time, I thought we might start to think about what are some of the ethical considerations for this. Not so much, I would love to hear your guys' perspectives, but also like as a way to get you guys thinking about how these ideas are salient in your own research.
I think that's really great. I want to say a couple things. One is the first study that you presented is really a better illustration than we came up with yesterday of why you need a community advisory board.
Oh, mm-hmm.
Because we had this discussion and presentation about CABs yesterday, but really the expertise of your participants and others who interact with them, those quotes vividly illustrated exactly why you would want to have people who can tell you those things, because it's really helpful. The other thing that I think is really interesting, and we're going to go around and talk about ethical considerations of your MRPs and things that may come up as we start to anticipate this. And what's really interesting to me is this, again, illustrates it's not loss of confidentiality. That's not the big, like, that's the easy one for us. That's the low-hanging fruit to say. What's really a concern is that someone will see your data. But when you talk to participants, again, in your first study, that's not really what they talk about in that language. They may be talking about 3 steps down from someone seeing your data. So as we think about this, trying to think, extrapolate from the event you're worried about to what it really means for somebody. It's an abstract exercise because those people aren't in the room with us yet, but I think that's a good way to think about it.
Mm-hmm. Yeah, and then the other thing I would suggest too is to think about it, so one, how do these things relate to the different Belmont principles, right? And then for you guys, specifically as you're thinking about your studies, it's like, what's the work that needs to be done prior to implementation? So like, what's the emphasis in your piloting, right? And getting your instruments ready, developing your cab, etc. What's the work that needs to be done during implementation, especially if you're doing like an mHealth study and you're having people participate like daily in something? And then what's the work that needs to be done at the end to understand the participant experience? And these two should really mirror one another. So should we, do you want to do this for sense, or does it make more sense to do it
so
for
let's
these?
jump in with, I think that we're all fishing out of the same ethical consideration
Exactly.
pond, and so you're going to hear things that cross projects, obviously. So who wants to go first and talk about, again, the potential ethical considerations for your MRP?